There you go. Thank you. Today for our faculty spotlight lecture, we have Dr. Wiley. We will hear about her success and accomplishments and achievements. So buckle down and join us for the ride. I will go ahead and kick it off to Dr. Wiley. Go ahead. Oh, actually, before I do that, let me just do this here real quick. I want to be able to read the bio. Okay, here you go. Dr. Wiley has spent much of the past 25 years thinking about viral infections and human health, including cancer, human papilloma virus, HPV infections are common. However, HPVs cause human cancers that are rare. Dr. Wiley researches and studies the way we think about cancer prevention, screening, and treatments. She obtained her associate's degree in nursing from Grossman Community College, her bachelor's of applied arts and sciences in nursing from San Diego State University, and her master's in public health from San Diego State University, her PhD in epidemiology from the UCLA School of Public Health. All righty, I'll pass it over to Dr. Wiley, and we'll go ahead and take it away.
Thank you. I hope you can hear me. So I want to thank everybody for coming, and thank you, Mr. Espinoza, for inviting me. And I really want to thank the School of Nursing for making it possible. So we're just going to talk about HPV infection sort of as a model disease, in the sense of that these are things that nurses think about a lot and try to make people's lives better in many ways. So one of the things to think about is incident infections, because these are really, really common infections. They're becoming a little less common for the cancer-causing viruses with the introduction of the HPV vaccine for females in 2006. And in 2009, it was introduced for males. We vaccinate people that are 9 to 27 with on-label recommendations, and you can get vaccination all the way up now to 44, but we'll talk about that at the end. So with incident infection, these are sort of the estimated incidence of people 15 to 59 years of age. This is 2018 data. The pandemic sort of got in the way of a lot of routine, data collection over those many years. So this is Lewis's work. And what it's saying to you is that basically you're going to see in men and women an equal number of infections. And these are any infections. And one of the things to warn you about is that HPVs sometimes scare the pants off of people because there are more than 100 different viruses. But of those, only 12 of them are known to be human carcinogens. And another 13 of them are classified as group 2 carcinogens, meaning that they have some probable mechanistic way to be associated. So when you think about 11.8 million people per year, this is usually after the onset of sexual activity. So what you tend to see is these infections are very common through the late teens and into the 20s into the United States. And by the time most women are 30, which is the population we know most about. So of men, what we know most about is less about heterosexual men on average. We know a lot about gay, bisexual, trans, and other men who have sex with men. So we know a little bit less about men. So much of what I'll talk about today is based upon what we know about women. When you look at disease association, you see about 6.1 million cases of disease, meaning that people report to their providers for some sort of a problem. And they can be, usually they're anogenital HPV infections. Very commonly, what we've seen in the past is about 160,000 per year, new ever first time contacts with a provider over having genital warts, which is what started me in this particular, this field in the 1990s. And so you'll see that it's a little bit lower in women than it is in men. The IARC group 1, those are the carcinogenic infections. So about 5.3 million folks in the United States, about 6 million men. And then HPV 6 and 11 in 2018, remember we had been having more vaccination, though we're not at a stage where we need or want to be. but you were still seeing for 6 and 11, which cause genital warts most of the time, those were about 0.2 million or 2%. So when you look at prevalence, when you look at the world versus the United States, North America is here. What you tend to see in the virus types is that HPV-16 is a very different virus. It's a pathogenic virus. It is an HPV. It's been well known to be associated with cervical cancers. So when you look in cytology, meaning people's Pap tests, and you ask how common is HPV, it's about 5.8% of those normal cytologies, you're going to find HPV-16. But when you look in the cancers, it's close to 72%. And so what that's really telling you is that while it may be an infection that affects a lot of people, when you get to the point of a cancer that's evolved, it's very commonly found in those tumors. When you look at HPV-18, which is the second most pathogenic virus of this virus type, what you tend to see is a little bit less dramatic. In North America, it's found in normal cytology. You're finding it about 2.3% of the time, but you find it close to 7% of the time in tumors themselves. So again, these are more pathogenic viruses because they're not terribly common in and of themselves, but they tend to cause persistent infections. And that's the one thing that we've learned about HPVs over the years is it's that persistent infection that is important. So if you look at cervical cancer and you look at the tumors, about 72% of the tumors are associated with HPV-16. And so if you ask me, does that mean that's the only virus they have on board? That's probably not the case. They often have more than one type. You'll see about, depending upon how you look at the numbers, of the cancers, about 88%, 89% of the cancers that are cervical cancers in the United States are actually associated with a pathogenic HPV. But then 12% of them are going to be due to other types of HPVs, and these are the other types that are also covered in the vaccines, which we'll talk about at the end. And about 7% of them are going to be HPV-18. So if you get down to persistent infection is why we've changed all of our screening guidelines, because trying to find the needle in the haystack, because even though you see these very common infections in your 20s, by the time you're into your 30s, most women have cleared their infections. It takes usually up to 2 years. And they go on to not have any problems. It's those persistent infections that you start detecting in the 30s where they test repeatedly positive that are associated with cancers that start occurring in women at about 42 years of age. So HPV cancers are unlike other cancers, they're called bimodal, meaning that they have 2 humps. So the first big peak that you'll see in cervical cancers is at 42, and the second peak is going to be at 61. And that may be because of issues related to the pathogenesis of the viruses, but it also could be due to some host factors. So this is just the natural history that people work with when they think about this, because normal epithelium is what everybody wants. And so incident infections could lead to HPV detection. And whether or not they progress, they can actually clear, and most of them will clear within about 2 years, and it goes back to normal epithelium. But some of them develop these sort of mild atypias. So you look under a microscope and you'll see these unusual shapes to the cells in the cervix. And everything I'm saying about what you're seeing in the cervix is what you see in all tissues that are suffering from HPV infections. The virus itself tends to bind to the epithelium. It needs keratinocytes in order to reproduce, and it starts in the basement layer of the skin. And so it starts replicating, and what happens is that these nuclei become very large and very dark because they're just filled with virus particles. And as they ascend through the tissue as it develops and is shed into the environment, such as in the cervix, in the anal canal, in the oropharynx, that's where we're detecting the infection, but the infection is actually going on really at the basement layer. So you'll see these mild changes, these very large cells. They have these ground glass appearances because their nuclei get so big, it crowds out all the cytoplasm, and the light coming up through the bottom makes it look like it's sort of an eclipse when you're looking at it. If they go on to persistent infection or to high grade, both of those, the risk is if you have persistent infection, that in fact, what this virus tends to do on average is that it sits and grinds away in a cell and it causes replication. So the cell just keeps dividing when it normally would stop. And so because of that, what it sets up is this little laboratory where all sorts of genetic abnormalities, just from the process of replicating the cell over and over and over again, those polymorphisms that develop, you can actually end up hitting a gene that it would not be convenient for you to hit. And so the long and the short of this is that they accumulate over time. High-grade dysplasia can actually develop, and those are called precancers. They can regress. They can regress with treatment. We've now shown that now we can prevent invasive anal cancer, for example, by treating much the way that we're treating invasive cervical cancer. But some of the tricks to that we'll discuss at the end are about the questions about how to screen. And then those cells, those high-grade dysplasias, that are these very circumscribed lesions, you can biopsy, look at them under the microscope, see that they're a precancer. You can remove them either by cutting them out or burning them out or treating them. Those will just sit there percolating until you get enough of an accumulation of abnormalities that you get an invasive cancer. And then those cells, they've achieved the ability to not depend upon inhibition for their growth, and they can migrate to other areas of the body. So this is just showing you a picture. On the far left, you'll see viral infection. Again, that's the top of this is sort of the outer layer that you're looking at when you look in a colposcope, when you look in an anoscope, when you be looking with some sort of a device into the oropharynx. Where the infection is happening is down there at the bottom. That's where all the action is. And as the infection progresses, what you see are those yellow cells, which have really large nuclei. Those are going to percolate up into the other layers, into the granular layer, up into the stratum corneum. And what you start to see as you move towards the middle of the screen is the abnormalities become more and more common. And what you normally should see on the very far left are those cells that look like ghost cells. You can't really see their nuclei because they flatten out and the nuclei become very transparent and they're shed off into the environment like a little ghost. As you move towards cancer, not so much. You tend to see these large nuclei. They tend to accumulate. They run through all of the areas, the different strata in the epithelium. So when you think about cell damage, cell cycling, release of growth inhibition, those are the major characteristics of things that are heading you on your way to high-grade dysplasia, precancer, and to cancer. And one of the things I often stop and talk about, especially in my public health classes, is that there's a tendency when we're thinking about policy, and anybody who's heard me talk in my class, I think that if we operated more understanding that when we make policy, we have really great impact on people, maybe who we weren't really thinking of when we were making them. And I tell my students that if we all operated as though we created policy, assuming that all of us were at risk, in other words, that none of us are special, that we're just next, we might think about it differently. So this is one of my favorite guys. This is Mo Brooks. He's the House of Representatives. He's now stepped away, but he was at this time when he made this statement in 2017. And he basically said that, you know, people who don't live good lives, right, that maybe they should pay more money for their insurance rather than being covered assuming that. So this data is actually demonstrating this. Tomasetti and Vogelstein is somebody's work I've followed since the early 90s, and he's really quite brilliant. He's at Johns Hopkins, and one of the things he and Tomasetti wanted to look at was, are most cancer really being triggered by accident, meaning that it's nothing that the person really did, versus environmental cancers, which we know there are some cancers such as lung cancer that are associated with smoking. But having said that, there's lots of people who get lung cancer who never smoked. And so what they started looking at was this idea, because you need stem cells that are going to become abnormal and be the genesis of these cancers. So what they looked at was the total number of cell divisions in stem cells, and then they plotted that against your lifetime risk of cancer. And so if you look here at the top, FAP, familial adenomatosis polyposis, FAP, that causes colorectal cancer, and in a non-surveillance world, meaning that you don't look for it, you just wait and time, almost 100% of those people will get a cancer because they have a mutation in their in one of their genes that essentially is going to govern how many abnormalities and polymorphisms are going to develop in the cell. Many of these are related to DNA mismatch repair genes. And so this would be one of those cancers that has close to 100% chance if you're not doing surveillance and treatment. You go down way at the other end of the scale, head osteosarcomas, pelvic osteosarcomas, lots of osteosarcomas, they're all down here. These have very low stem cell divisions in those tissues. Okay, so FAP would represent something in a tissue that in fact, due to a genetic inherited characteristic or a spontaneous mutation, these folks would have a very high cell division rate in their stem cells. So if you're asking what causes cancer, what Tomasetti and Vogelstein did was they did some really fancy razzmatazz with machine learning, and they looked at this relationship and they found that it's highly relevant, that you have a small number of cancers, which are these blue bars on this side, one of which is an HPV-16 oropharyngeal cancer. They eliminated all those tissues for which we don't have reliable data about their stem cell division rates that normally occur, and they looked at the prevalence in the population of disease. So all of those that are in blue are actually things that one would consider to have a high influence of an environmental cause. Everything on the left has a very low risk score, meaning that these are almost by chance alone. So it gets back to my point about the fact that when we make policy and we try to think about all those ways that we could penalize somebody who smokes as opposed to helping them to stop smoking, it doesn't guarantee that the cancer that they are getting necessarily is something that's all their fault. Okay. So when you look at this accumulation of genetic damage over time, you start to see precancers, precursor lesions, neoplasia that's evolving. When I started in this field, what I was working with was I had started as a postdoc working with the American Medical Association as a scientific consultant. And what that really means is that I was a very fancy gopher. And I supported one of their expert panels to do a deep dive into understanding genital warts, which are a form of neoplasia. They're just not malignant. And basically, what becomes really obvious is that HPV 6 and 11 is really important. So if somebody says to you, why are you giving me a vaccine that includes a genital wart vaccine? Because there was a huge uproar at the time of whether the administration would allow a vaccine that protected against genital warts, because we know that only nasty people do those things. The whole conversation was that the reason we do this is because that form of neoplasia completely mucks up our entire screening program. because we depend upon being able to look at cells and not see this effect of lots and lots of HPV 6 and 11 genital wart kinds of changes in cells so that we can actually get to the nitty gritty of finding people that are at risk for cancer. So it improves our screening system if we do nothing but wipe out the HPV 6 and 11 infections. And then we started by, and I was working with Merck in the early, we started in 99. We finished the first study in 2004 and published on it and showed that we could have almost 100% efficacy in 16 to 27-year-olds by looking at vaccinating against HPV 16, 18, 6, and 11. Okay, so if you want to look at cancers that are associated with HPV infection, one of the things to remember is that HPV cancers affect oropharyngeal cancers, and they disproportionately affect men. So one of the weird social media things I think is remarkable is that people are trying to think about why, in fact, that 13.9 versus 81.5. And there's this whole mantra that I've seen on social media about how it must be because men are having oral sex. And so, not embarrassing anybody that I talk with, but the reality is most women I know in their lifetime have probably had oral sex, and we still only see 13.9%. So what we may be seeing on the right is the effect, number one, of not having competing organs, meaning that men don't have a cervix. They do have a perianal space that sort of mimics things going on in the vulva. They don't have a vagina. So the long and the short is that those distributions may be different because there's different organs affected in the two sexes. But you may also very much see a difference in the risk factors that are compounding risk factors. Because if you think of HPV as doing nothing more than increasing the random chance that you're going to get a cancer, then all those things that also amp up the risk for cancer also affect HPV. So we know that, in fact, if you are a smoker and you're female, we can actually detect the agents of tobacco in the cervical mucosa. So this whole idea that somehow these are all operating independently, they're not. They're all involved with one another. So in women, we still see about 50% of the cancers that are HPV related are in the cervix. In the United States, by spending $1 gazillion per year, we actually have that rate down to about 8.8 cases per 100,000. It's disproportionately high in African American women, Latinas, and also in Vietnamese women. When you look at Asians, they have both the highest and the lowest rates of cervical cancer because Vietnamese women have rates around 49 cases per 100,000. Whereas if you look at women who are Japanese, their rate is down around 1 to 4 cases per 100,000. In the vulva, you've got competition with other sort of autoimmune diseases like lichen sclerosis. Only about 40% of the cancers of the vulva are due to HPVs. And again, they're usually due to HPV 16, 18, and the other 10 viruses. In the vagina, people refer to the vagina as being a tough tissue compared to the cervix because the vagina and the cervix are closely approximated. So it's not the absence of virus, it's the difference in the tissues. In the anus, in males, women have more HPV-related anal cancer than do men, okay? But first, I want to talk about men, and then I'll come back to women to explain some of the differences. In anal cancer, in general, in males and females, the highest risk groups are people who've had an organ transplant because of immunosuppression. Also, HIV is a major immunosuppression, and even in effective care, they have higher rates of anal cancer than you'd see in the general population. So most of the risk, you're really talking in MSM that I work with, their rates of anal cancer vary depending upon whose estimates you're looking at, between 80 cases and 130 cases per 100,000. So it's still a rare event, right? But in women, Most of those cases are not due to HIV. They are not due to immunosuppression. They are truly at risk if they have organ transplants, but that's not the majority of them. So what we see is that the recommendations now that are being discussed and being published are about looking for lack of a better word, sort of low-hanging fruit of people that you would know have a high risk for disease to do screening. So it's recommended in the organizations that I belong to that HIV-infected MSM, women who've had a history of HIV, or if they have a history of cervical high-grade SIL, receive screening as well. But when you get right down to it, you cannot explain 59% of the cases of anal cancer in women by any risk factor. And the problem is that it's like looking for a needle in a haystack, because the disease rate in the general population is 2.2 cases per 100,000. And in men, in the general population, it's 1.4 cases per 100,000. So when I work with providers, what they're really focused on is they want to find every case of cancer. And we will bankrupt this nation if we screen everybody rigorously to make sure we get every cancer case. So we have to learn how to think smartly and think about how we use our screening tools. So treatment, I'm just going to go over a couple of them superficially. Suffice it to say that if you're dealing with HPV cancers, you're going to be dealing with, in all of the modalities, with chemoradiation therapy. You will deal with surgical treatment in cervical cancer, as well as with vaginal and vulvar. You don't see an anal cancer treatment that involves surgery at this point. Largely, there's one condition which is superficially invasive squamous cell carcinomas. There's some conversation and some clinical trials looking at, modest treatment to see if you can actually control it. But the treatment that people with anal cancer receive is chemotherapy, which is mitomycin C, and platinum drugs, as well as pelvic radiation. So the long-term effects of that are pretty significant. When you look at, so just so you know they're out there, this is really small writing, so don't get lost in it. External genital warts, most of those are going to be treated either with immunomodulators like imiquimod, also podophyllin, which is an old-time drug. You get it now. Most people use Podophylax, which is something that is marketed. And then they also use cryotherapy, and they will use some surgical ablation in order to remove them. You can snip them out with scissors, because pedunculated warts, they look like that little mushroom sort of shape that you expect to see. I didn't put a lot of pictures in here because people sort of get the ick factor. For internal anal genital warts, treatment is much the same. The difficulty that you have, for example, trichloroacetic acid is something that's used in genital warts for treatment, but using it internally, if it's too runny, you can actually damage other tissues and cause other problems. But cryotherapy is used, some surgical removal. We use electrocautery for removal as well. If you look at anal cancer risk among people that have organ transplants, this is a meta-analysis that was looking at just the standardized risk. So what you'll tend to see with people with organ transplant, they have a 5 to 6-fold increase in risk. When you're looking at people with anal cancer with HIV, in men who have sex with men, you're really looking at an increased risk of maybe 40-fold. So this is telling you that risk is something that you have to really conceptualize within the risk factor when you're advising people. Otherwise, everybody thinks your hair is on fire. And so that's not a good place to have with a patient where they're so anxious when you look at this. When you look at the incidence rate in people that have organ transplant, it's about 10 times higher per 100,000. Okay. So screening. So when we get to prevention, the important thing just to go over is that cervical cancer screening is being modified in real time. You're living in a time where, because of the vaccines and bringing down the rates of HPV 16 and 18 infection, and in the United States, an additional 5 others that are contributing, we can get rid of 90% of the now known cervical cancers. So we're having to do less screening. We don't have women marching in every year since 1955. The recommendation was to march in every year and to put your feet up in stirrups and to have all these tests. So what I'm trying to show you in this particular table is that there are combinations based upon risk stratification. So if you're looking at people under 21, they no longer screen those people. The rates of cervical cancer are very, very, very low. And so when you're looking at 21 to 29-year-olds, what you really want to find are people that have high-grade SIL. So these are the precancers. And so they're recommending cervical cytology every 3 years. The reason for that is we know that if we don't pick it up, we still have quite some time to find it before it evolves to a cancer. The natural history is such that we think that that whole cascade of events to get to a cancer from primary infection is somewhere between 10 and 20 years. Okay. You can consider, if you're 25 to 29, although it is not the preferred method, to just have HPV testing alone. There's a lot of people that are promoting this as a possibility simply because we could get to women who refuse to come in for cytology. And this is being discussed with anal cancer screening as well. There's some caveats I have to that. We'll talk about them in a minute. But in 30 to 65-year-olds, this is where we get into co-testing. And the reason is that if you test HPV negative and you have a cervical cytology that's within normal limits, then the probability that you will get a high-grade SIL within 7 years is very, very low. So they set this metric of setting you up to test you. And if you're negative for both those parameters, they're going to be able to not see you again for 5 years. And the odds are that you will be very well. Okay? If in fact, one of those tests is abnormal, they're just going to screen you more often than every 5 years. Again, not getting women into a panic over having a positive test is really important, because though most people are going to clear their infections by the time they turn 30, there's some that won't. Okay. And then also cervical cytology alone, if you're going to use it alone, would be every 3 years. You just continue with the recommendation through the 20s. And if you're going to do HPV testing alone, you do it every 5 years, just like you would with cervical cytology. When I explain this to women about why we're doing 2 tests, what I explain to them is that in the United States, that as much as possible, any cancer is what we want to avoid. So what you're really looking at is belts and suspenders. You want to make sure your pants don't fall down when you're at a party. So if you wear belts and suspenders, that's not going to happen. So if you've got a cervical cytology and an HPV test every 5 years, the likelihood is you'll find it. For the stop rule for women, 65 years of age, if and only if. The most recent test performed is within 3 to 5 years and of when you're considering to discontinue. And then they have to have no history of severe abnormalities or even moderate abnormalities or cancer. And they need to have a screening test history within the last 3 to 5 years. What they usually say is 10 years, where you have 3 negative cervical cytologies and 2 negative HPV tests, or you have 2 negative HPV tests in a row for the past 10 years. So you could have 1 test done every 5 years and that would qualify you and you could discontinue. Part of the reason for this is that if you look at the history of cervical cancer in women, the highest rates in African-American women before the onset of the vaccines was in 80 to 84-year-old African-American women. And so you want to make sure that they're not just being exited out of screening because, oh, I turned 65. You want to make sure they've been screened properly. These, I'm not going to read these to you. This is a proliferation of all the different anal cancer recommendations for screening. They generally involve 2 things. One of them is a digital anal rectal exam, which is different from a digital rectal exam. A digital anal rectal exam by IANS, the International Society of Anal Neoplasia. What they're really recommending is that for the first 5 centimeters beyond the sphincter, that you do palpation in the full circle. You don't just put your finger in and waft it around and say that's a digital rectal exam. You're feeling for thickening, you're feeling for any kinds of masses that you can palpate below the surface. And if those are positive, they need to be referred for further screening. And then different people use anal cytology. It's not my favorite test in anal disease because you have to set the threshold so low that you send almost everybody in high-risk groups off for diagnostic follow-up, which can cost, well over $2,000 per person. So if you're interested in this, I'm happy to talk to anybody, but I won't belabor it. In addition, I just want to give a plus. This is the vaccine that was actually replaced by the 9-valent vaccine. It's performing as well. But what I wanted to show you is Dempsey's work. She and Laura Kautsky did some work in the ADD health in the mid 2000s. And what they were looking at was a lot of providers and a lot of families were saying, gee, my daughter doesn't need to have this, or my son at that time was not eligible. But I, the provider, the parent, could decide if my child was high risk. And that what her data shows is that's not true. Because what comes into play when we talk about high-risk people, going back to Mo Brooks, is all of our biases about people. And so when you really look down and look at it, is that if you looked in this group of the ADD health group, in a sample of about 4,000 people, 18 to 26, what you would find is that the vast majority of them were negative for all 4 different types that were included at that time in the vaccine. And only about 9% of them had one, and very, very few of them, exquisitely small number of them, had more than one HPV that they had evidence of ever having on board. And then if you look at this about not vaccinating women with more than, because people were circulating at that time, providers were saying, well, I'm not going to vaccinate people if they've had more than 3 lifetime partners, or I'm not going to vaccinate women who've ever had an abnormal Pap test.
Oh, wow.
If you look in a population, a large population of close to 2.5 million people, if you look at the proportion that have no current HPV 6, 11, 16, and 18, the vast majority of them do, 88% of them. So the idea that you are withholding a preventive treatment that could benefit people, even if they've had genital warts, they probably haven't had HPV 16 and 18. So 3 injections in that age group over the age of 15 would be important. I'm just going to also show some work we've been doing at UCLA. My partners, I won't say my partners in crime, they're my definite partners that I value highly. Marilyn Breck, Lauren Clark, and then Nipa Walda, myself, and then 2 students, Yuriko Matsuo, Amanda Baruman. This is some work that we've been working on, looking at children with developmental disabilities and complex chronic conditions that have been diagnosed in pediatrics. So what we looked at is in the Optum Health data. It's a big data warehouse. About 1.5 million kids were 9 to 15 years of age. So they're born between 1999 and 2005, just before the vaccine was approved for girls. But the bigger issue is that we started our observation in 2009 when it was approved for both boys and girls. So what we looked at was we had 3.3% of the children who had autism, cerebral palsy, intellectual disability, or spina bifida. Of those, if you look at these 12 domains of pediatric complex conditions, they account for 25% of the mortality of children under the age of 18. And so what we found is 65.7% of those kids who are already 9 to 15 have one or more of those versus 34% who didn't. In the 1.5 million kids who didn't have these 4 developmental disabilities, only 33% of those kids had one or more of those conditions, meaning that even though those conditions are associated with a high risk of mortality, they're accounting for a high fraction of the mortality in kids under 18. Many of them are surviving, and they're now surviving into adulthood. So we used to see cystic fibrosis when I became a nurse, which I won't tell you how long ago it was. Those children on average died before puberty, or just into puberty. People with HIV, when I was first in the field of HIV in the early 90s, we were still seeing vertical transmissions. We now have treatments to prevent that. So those children also suffered early immune deficiency. Those kids, if they acquire HIV, they're living into adulthood. So many of these conditions are conditions that are following people into adulthood. So why wouldn't you vaccinate them? Because the assumption that people keep making is that because you have a disability, you won't be sexual. And what we know is that people are sexual either by their desire or not. And so the idea that you would actually impact them differently. What I will tell you that we found, I'm just going to go from the top, the kids with cerebral palsy were 6 times less likely to get a vaccination than children that did not have cerebral palsy. The children with intellectual disability were about 3.3-fold lower odds of getting vaccinated. The kids with spina bifida and autism were about 2 times less likely. Females and males. Males were a little less likely, again, because 2009 was when it was coming up. In females, they're about as likely as, they were the comparator group. I apologize for that. If you look at the number of provider visits, we saw anywhere up to 1,800 days in 5 years that these children could have been seen by a provider. Most of them on average had about 6 provider visits in the 5 years. So there is an effect of that, so we control for it. What you see across all the years is compared to 1999, all the way across the period, the vaccination odds were going up. And then if you look in just controlling for the effect of these chronic conditions, children with transplant were less likely. So remember, I told you they're at high risk for HPV cancers. Yes, indeed, they do get immunosuppressive drugs. Does that necessarily mean that you would not immunize them? That's one of the things that I find interesting. Children with technological dependency can be anything from having a shunt to having a G-tube. So it's it's broad. It doesn't mean they're just on ventilators. Hematologic kids that have hematologic disease and immunological disease are less likely to get a vaccine. Kids with GI difficulties, kids with neonatal that had neonatal prematurity and so forth, and diseases associated with that, their odds are about the same. They're slightly lower, but the confidence interval crosses 1. The same with respiratory. But here was the thing that we were surprised about. Children that had these respiratory diseases that are often increasing their risk for death in childhood, they were more likely. Kids that had cardiovascular disease that was making them at higher risk for mortality, they were more likely to get a vaccine than kids that didn't have these conditions. I truly understand why parents who have children who've had prior malignancy would take one more cancer cause off the table. It doesn't surprise me that those children are getting more vaccination on average. Kids with congenital abnormalities, interestingly enough, had the highest. So if you summarize them, we've got kids who have higher odds and kids that have lower odds. None of the children with developmental disabilities came into the higher odds group. They were all at the lower end, and at best, they were in keeping with what you see with transplant kids. Okay, so something is going on. We need to change. So if we're talking about prevention, all I can say is the vaccine, if you vaccinate a child at least 1 dose before they turn 15, they only get 2 doses in their lifetime. You can cut down the cost of the immunization program by 1/3. If you wait until they're 15 years old, they get 3 vaccinations. So if you want to think about The new American Cancer Society initiative is going to be start at 9, is the laments that we're making. I'm working with the cancer, with the HPV roundtable, and you can open it up to everybody. The HPV roundtable, we're trying to get immunization rates up in general in the population with all the things I just described to you. Controlling for all those factors, we only see about 49% of kids being vaccinated by the time they're 15, which breaks my heart. So.
Wow, thank you. That was fascinating. We're gonna go ahead and open it up for Q&A. If anyone has any questions or comments or follow-up notes, can we go ahead and do that now? Yeah, you can.
Did I talk too fast? I hope.
Oh, no, you're fine. You still have 10 minutes.
Okay.
So
I was hoping to get through all the data.
Yeah, if you have any questions, feel free to unmute yourselves and just drop it. Or do you have any questions or comments?
I can start, sure. You were saying that half of kids are getting the vaccines before 15. In the kids with developmental disabilities or the chronic conditions, is there an age differential?
Yeah, what we see in this 9 to 15-year-old age group, I was going to show you a slide that I have on that, but it confuses people, so I don't use it very much. The reality is what we tend to see is that children with developmental disabilities, if they're getting vaccinated, they get vaccinated more often in the 13 to 14-year-old age groups than in the 11 to 12. The CDC has been really good about pushing and pushing and pushing to move. At the beginning in 2009, you see lots of people getting vaccinated at 13 and 14, right? And they move them slowly to 11 and 12. We're trying to move them back to 9. And the reason for that, the Cancer Society has really decided that one of the biggest complaints you hear out of parents is, my child is not a pincushion. You hear this a lot. Anybody who's on the call who's a pediatrics person, you are. Nobody likes, I've heard moms, and I remember with my own children, you know, those first visits you bring your baby in for, and they give 3 or 4 different shots in different locations. You know, the mom's crying as much as the baby is, or the dad's crying as much as the baby is. And so parents have made that really clear. So what's the adolescent platform? The adolescent platform is Tdap, meningococcal vaccine, and HPV, and you're going to get multiple HPV with 2 meningococcals. So if you start before 15, you're going to get 2 HPVs, 2 meningococcals, and by the time you're 16, and you're going to get a Tdap. And then if you have any high-risk conditions, you might get more stuff. But the long and the short is that by moving it to 9, there's no vaccine at 9. So you can actually offset that anxiety that families have about getting multiple injections. The other thing that I'm starting to hear more and more conversation among providers is we need to spend some time, because around the world, so my international colleagues, in their countries, they talk about it as the jab. In the United States, that has a really sort of violent connotation. You know, it's not cute. People don't like it. And so we need to spend more time on interventions that actually decrease discomfort associated with just getting a vaccination. My goodness.
Something that I found very interesting was that you said that even though there are environmental factors that contribute to somebody getting a type of cancer,
Mhm.
there's also all these other variables that we really just don't know enough.
Right.
And
They actually believe it's stochastic. It fits a random model.
yes,
It's random.
yeah, it's
And
like
so
a
that
lottery.
gets back to my,
It's like a lottery.
it's
like,
an unfortunate lottery nobody wants to win.
exactly.
So again, the reason I went into public health and am deeply committed to it is that, you know, we swim or we sink together. We've shown that time and time again. It doesn't mean you can't be an overachiever and you can't do great things in the world, but the idea of leaving people behind because of the biases that we have and develop,
Stereotypes.
whatever our biases are,
Yeah.
it's not helpful. It doesn't help us because if you really think about it, none of us are special. We're potentially next.
Oh,
you know.
interesting.
And in addition to that, if nothing more, being able to prevent cancers, to be able to discover disease early before people are disabled. If you're just going to be selfish, to keep the workforce going, to make sure that
Right.
when you want to go to Target or someplace else, somebody's going to be there to take care of you
Yeah.
or to your doctor. And so if we think of this more, not as a privilege to have health care, but as, people don't like, there's a whole community of people who don't like it when I say, well, it's a right. It's really in my best interest that you have health care. Okay. So I really ascribe to the not special model because if I live my life that I'm not special, I'm potentially just next. I make different decisions about what I do. And so a lot of when we talk about, when I teach in public health about things like emergency preparedness, I had a conversation this week with a former student of mine, and she was saying she lives out in the desert and that she has neighbors that they suddenly are getting big bills for fire insurance.
Oh,
And I said, well, that's true. And she said, well, but they can't afford it. And I said, that's the problem. But the reality is nobody in Paradise, California expected a fire to roar through and kill 84 people and ruin a town and rush them out of valley. Those things happen. None of us are special. And so it's, unless you're going to blame them for the choice of where they live, which doesn't seem very smart to me,
Yeah.
it could happen to any of us. We live in Southern California, the land of earthquakes.
Yeah.
So there's lots of times and places. And if we operated more on understanding that we're not asking for Cadillacs, we're asking for people to have basic access to health care, to be sure that in fact we can ensure that the population is healthy.
Yeah.
But that's hard. It's public policy, and public policy is messy. It's very difficult. It's like making sausage.
Yeah. I really like the way you frame it in terms of just kind of like living a life that with like some sort of assumption manner in a way that like I may be next.
Right.
I wonder like if more people adopted that mindset, we would be more grateful for being alive and like maybe enjoy our lives more.
Yeah.
Yeah.
So, when it comes to screening, one of the difficulties, for example, in working in the community, I've worked for the last, since 2002 is when we opened our first study in, neoplasia. I've worked on the anchor study that was just published recently that's shown that we can prevent cancers if we treat them, the precancers. The problem is, how do we find them without breaking the bank? And so I've come into acquaintance because I've worked with, in the HIV community since 1990. And the long and the short of this story is that in my work in EANS, I've grown to know more of the 59% of women who have no risk factors. And to hear some of their stories is stunning, because we can't do this level of screening on everybody where we're screening them once every year with anal cytology and as a separate test, and
Yeah.
then sending people off, because you're going to get a lot of false positives. And anybody will tell you that getting a positive screening test has its risk too, because you could be treated and not necessarily need treatment, but there could be side effects from the treatment.
Wow.
So you've got to balance all these things out and develop better skills. So I'm working with some colleagues on trying to come up with a better way to screen women who have no risk factors,
Wow.
where it wouldn't really cost, we don't think it would cost much more.
Wow.
So
That
I'll
is,
tell you if I'm
yeah,
successful.
that sounds
next
very
year.
interesting. I keep picking up on the fact that you keep saying that's too expensive, or we don't have the funding, or we're gonna break the nation because of this. And it's just like, wow, I didn't realize that so much of
Healthcare?
healthcare, yeah, is just
Sure.
money.
Yeah.
Like it really is just money.
Well, we can't send kids to college anymore in
Yeah.
California. So I can give you a recent thing. When I graduated with my doctorate from UCLA, and we used to complain about paying $600 a quarter for our tuition and fees. Actually, there was no tuition, it was just fees. And now it's $4,000 a quarter. We can send many more people to college if we're not unnecessarily spending money on things we don't need to spend money on. We can't build a library, we can't repave the roads.
Yeah,
You can't put your GDP, your whole gross domestic product into healthcare. It just won't work. So you have to be very practical.
yeah,
And practical is hard because it's such a passion of all of ours. There's
yeah,
nobody on this call, nobody in this building who isn't passionate about healthcare.
yeah,
But we also have to stay in our lane.
yeah. Wow, that's incredible.
Yep. So it's fun. Any questions in the
Awesome.
box? I can't see your
Let's see,
question.
The questions, I don't see anything in the chat.
Okay. Thank you all for coming.
Yeah,
It's
thank
nice
you all
to
for
see you.
joining us today. If we can go ahead and, I don't know if they stopped the recording yet. Okay, let me see. I'll stop the recording right now. Here you go, stop recording.